all here today at noon. This is an incredible opportunity for all of us. What I wanted to do is thank you for finding the Institute, because we've been having a lot of trouble ourselves. And secondly, I don't know if you rode up in the elevator, there's a guy sitting on top of it, and you knock on the door and he takes you up with the key. Nothing works. I also apologize for the fact that what we're doing is we're going to film the entire program today, and because our media isn't working properly, we will be putting it up on our website for people to view later. And so I apologize for everything. We just moved a couple of weeks ago, and as I say, we've just found our offices. So what I want to do is introduce Chris Klinger, who has been a member of our institute for 5 years, who has taken our courses, who has taught in our program, who has been an incredible advocate for hospice movement through the National Initiative for the Care of the Elderly. We have an end-of-life group where we prepare pocket tools for people who are working with people who are dying. And Chris has been a total moving force all across Canada in creating this, and also around the world, because we have 9 partners. And so I have to say, we really hope you never graduate, but we know you well. With no more ado, here's one of our favorites, Chris Klinger.
Thank you so much. Wow. Well, thank you so much, everyone, for coming out. This is the second international seminar that we're actually putting on with our sponsors, Hospice Toronto, the Toronto Central Palliative Care Network, NICE, the National Initiative for the Care of the Elderly, and last but not least, the Institute for Life Force and Aging. It's amazing to have this opportunity to have so many people out, and we're really glad that we also can use the video as one of the means to really get the word out about the initiatives that we're taking on here in Toronto, but also the international activities that are put on by NICE, the National Initiative for the Care of the Elderly, and our international partners. And we're absolutely delighted today to also have John Mastrojohn from the Foundation for Hospices in Sub-Saharan Africa with us today, who's going to deliver the keynote speech. So my role today is just to give you a little overview about the international hospice palliative care movement, the things that have happened over the last couple of years, and also to give you an outlook about the things that can happen over the next couple of years in terms of the changes that we're facing as a society. As Canada is aging, lots of people will actually near the end of life, and you know the number of people dying in Canada will significantly increase, especially since 2020. So I just wanted to give you a little flavor about those things, and also give you a little overview about the international hospice and palliative care movement before we delve into the keynote speaker and learn a little bit more about hospice palliative care service provision in resource-poor settings, which is such a desperate need all across the world if you think potentially about access to medications, access to drugs, but also the definite shortage of health human resources that are out there, especially in the medical field. So I just wanted to start off this presentation by just talking a little bit about what is hospice palliative care, what is the definition for it, give you a flavor about World Hospice and Palliative Care Day, which is celebrated all across the world actually this Saturday on the 8th. A great opportunity for people to reunite, but also to put awareness to the issue of hospice and palliative care, which is such a great opportunity to get the word out. And just also present a little bit about the international development initiatives that are going on right now, some of the research that is done in the area of hospice and palliative care, and also national associations that are out there to actually do work in this field. So just to start off, as we all know, hospice and palliative care is a very holistic approach to care for people at the end of life, for permanently ill people, not only in the cancer field, but outside of the cancer field, who just really need the support, who need pain medications, symptom management, in palliative care units, and also through hospice volunteers. And the approach really is a holistic approach, so we're not only focusing on the medical aspects, the physical aspects of care, but we're also looking at the emotional aspects of care, the psychosocial aspects of care, and the spiritual aspects of care. And the other important thing is that we're not only focused on the patient, but on the whole family. So it's the whole experience, the whole holistic care for the family, and we also include the component of bereavement care in this picture. Or, as somebody else at the Worldwide Palliative Care Association have said, it's care for people provided by people facing death, by people unafraid to face death. And that pretty much sums it up for us. So World Hospice and Palliative Care Day, the event that we're celebrating today, is actually coming up on Saturday as a joint universal event for hospice and palliative care. bringing a lot of attention to the movement, but also helping people to really get to know more about hospice and palliative care. And here in Canada, we're also talking now about advanced directives legislation, all those things that are connected with it. Living wills, for example, as one of the opportunities to start thinking about the issue very early, and also to have plans in place for the care that you want at the end of your life. So this year, we also have World Hospice and Palliative Care Day again, together with Voices for Hospices, which is a series of concerts that are put up all across the world to really get attention to the issue and to also have an opportunity to bring on some fundraising experiences into the whole mix of hospice and palliative care. And as you see, the vision of the whole event is to increase the availability of hospice and palliative care throughout the world, and really this year also to have a focus outside of the cancer care. So the theme this year is actually called Many Diseases, Many Lives, and Many Voices. And there's a website there for those of you who want to look at some of the events that are put on, not only in Canada, in North America, but also all across the world, including sub-Saharan Africa. So some of the statistics, and this is statistics from 2009, where they had the event again together with Voices for Hospices. And you see there's a lot of those events going on in 74 countries all across the world, which is a very encouraging sign, because hospice is actually catching on in more of those countries, and people at least start thinking about those experiences. But you see the distribution at least is a little bit skewed. You have 10% of those events in Africa, 12% in the Asia Pacific region, 66% of those events in Europe, and 12% at least in the Americas. There were 311 Voices for Hospices concerts in that year, and we're just hoping that this year we'll see many, many more of those. And it's also encouraging to see that there's more and more media attention towards the issue. And I think that's one of the very important things to see, is that is this actually really gaining some ground in the media, and that are people more and more talking about it and thinking about it beforehand, which is the important aspect. And you see also that there's numerous addresses of support, and also some of the celebrities are actually talking about it now. So we had Archbishop Desmond Tutu from West Africa as one of the advocates, Dame Judi Dench from the United Kingdom, and here in Canada, our own John Mansbridge was actually an advocate in 2009, giving his media attention towards some of those things that are happening with hospice and palliative care worldwide. And then if you look at the levels of service provision, there's also more international attention now, and also more international studies in what is happening with hospice and palliative care all across the world. There's a dedicated international observatory for end-of-life care now at Lancaster University in the UK. And they do a very good job in at least mapping the services that are out there in the countries, and also starting to connect people, which is the important aspect. And it's definitely some comparative analysis that is available now, and it's also about the resources that are there, not only for the people on the ground, but also towards political decision-making, which is another very, very important aspect if you think about the funding of programs, and also making sure that those programs are actually sustainable. So what I brought you is an international world map, just to give you a flavor to see where those programs are actually located. And you can see that the yellow is actually indicating where there's no service activity in hospice palliative care at all at this point. And that's still quite a number of countries all across the world. The blue is actually showing some hospice palliative care activity, and we see that this is also catching on a little bit more in Africa, which is a very encouraging sign. Red actually indicates some localized activity, and you see that this is also a huge issue now for the Americas. And green are countries that at least are supposed to have programs in place that are providing hospice and palliative care, and their healthcare systems are also paying attention to the issue and starting to integrate the ideas of hospice and palliative care into the mix. And this is also very encouraging to see, and you see some spots of that in Africa, and you'll learn a lot more about them in the later presentation by our keynote speaker, John Mastrojohn. So The Economist also did an intelligence report about death and dying in the world, and looked at some of the comprehensive reviews from the countries that are going on there, creating what they potentially, as a little misnomer, call the quality of death index. But they really looked at basic healthcare service provision in this index. They looked at the costs of end-of-life care service provision, and also the quality of end-of-life care, and also did some key informant interviews to actually find out what is happening on the ground. So if I would ask you now, just as a guess pretty much, where would you think Canada came in this report? It was 41 countries, so you think Canada was somewhere in the middle, on top, perhaps on the bottom? Anybody venture out to say where you think Canada would fix it?
I think about a third from the top.
Third from the top, so
A third from the top.
A third from the top, okay. So pretty much in the upper. Any other guesses?
Middle.
In the middle, towards the middle. I don't know. Anybody else wants to venture out? It's an interesting question because also the question is, where's the comparator? So my other question would be, before I show you actually the result, is who do you think would be leading the pack? The UK? Anybody from the States here? Where you think they would fit in? Wild guesses? Above Canada or below Canada? Let's mark it that way. Below Canada. It's interesting, you'll be very surprised because the US and Canada actually came in on the same spot, position 9th. So you're absolutely right, in the upper field. And interestingly enough, also you see that the United Kingdom is actually leading the pack in this index, just followed by Australia and New Zealand. And one of the reasons this is happening is actually because there's a very good rooting of the hospice palliative care movement in the UK, just because of Dame Cicely Saunders and St. Christopher's Hospice. But there's also a lot of political initiatives going on in the UK right now that actually contributed to this spot. So the UK 2 years ago has actually established a national end-of-life care strategy, which came out of a cancer plan, and they also dedicated a lot of money towards this. So they made sure that there's a clinical pathway that is actually really backed up by a lot of money going to hospice and palliative care, and that definitely made a difference in the thing. There's still the question of the perceptions of death though, the taboo of death in some of those countries, cultural differences, and you'll hear a lot about those problems when we talk about Africa and the different cultural approach towards those things. So they're definitely still there. Another interesting thing about the report is that we also think about euthanasia, and that has definitely had an influence in the States. If you think about the last elections and you heard this terminology of the death panels that was used by Sarah Palin, or this other image of pulling the block on grandma, that really shaped the debate totally differently. And we also see now that this euthanasia debate is cropping up in Canada. You know that there's a parliamentary commission now looking in Quebec about the issue. So there's definitely a lot of talk about this, and it's one of those things that we also need to be very aware about. And especially in resource-poor settings, the final point seems to be a very important one. It's availability of drugs and also the actually distribution practices of those drugs. There's an international narcotics control board involved in this whole issue, so it's very, very difficult. And on the other hand, I mean, you cannot forget that pharmaceutical companies are also in it as a business, so they're there for profit. And that also has huge implications of who is actually able to get these drugs and how they are available. So in terms of the national associations, and that is picturing actually a better picture now, you see that there's more and more interest in national hospice palliative care associations, and there's also more and more guidelines towards practice and guidelines to care. And there's also more and more support for those organizations available through toolkits, but also through international organizations like the Worldwide Palliative Care Alliance. So there's definitely a little bit more support toward that, although it's very difficult to raise the funds and get funders interested in this area. And I guess that is a very international and common problem for people to have, to get funding towards this area. Again, if you look though into the distribution of those national organizations, you see that they are very skewed in terms of where they actually are. We have Canada and the US as actually very strong organizations. Think about the Canadian Hospice Palliative Care Association here in Ottawa, or the National Hospice Palliative Care Organization in the States. But only Africa has two of them, one in Zimbabwe and one in South Africa. Asia Pacific, again, the more industrialized nations actually spotting those societies. Think about Australia and Japan. And in Europe, it's pretty much becoming more and more of a fix. More of those countries are thinking about it, and more countries are actually trying to integrate hospice and palliative care into their healthcare system. And there's a lot of interest, and I think that's the other good thing that came out of the study that was done in 2005. There's at least 28 countries thinking about such organizations and really trying to also formalize the hospice and palliative care movement, bringing it from the grassroots level, where it had a start, into more of an organized feeling, and then also into the national hospice and palliative care system, which should be a part of the national health care system. So that is actually encouraging to see. And if you look again on the international scope, a report was actually done for World Hospice and Palliative Care last year by the Worldwide Palliative Care Alliance, and they found a lot of really encouraging examples also from other countries where hospice and palliative care is becoming a part of the healthcare system, especially in India and some of the provinces, but they're also trying to create communities through hospice and palliative care, taking care of people in a very holistic way, and giving some examples how communities can actually support people at the end of their lives and helping them to die what is a better death. Providing palliative care in prisons is another aspect. We also see a lot of impoverished people. We still have the problem, for example, of homelessness populations in Canada and providing services to them. There's also the aspect of rural palliative care, which definitely is one of those untackled issues that need a lot more thinking and a lot of more support. And we're also thinking about people with disabilities, which is also an area where the movement needs to be stronger and where we also need to come up with some of the solutions towards providing better hospice and palliative care to those people. So that is pretty much a quick snapshot, and I think that here, especially at the Institute and with our partners that are sponsoring this event, a lot of things have happened over the years. So we had done Dr. Sandy Buckman doing a report about hospice and palliative care in Malawi, and it's great to see that he's in the audience with Kevin Besançon, so that's really good to see. And we also had some encouraging work that was done by the partner Hospice Toronto coming out of last year's lecture, when you think about the Young Carers program that was presented to us from the UK. And it really caught on with them and is now an initiative that they're actually providing as a service. So a lot of those international aspects of hospice and palliative care have also ventured into the Canadian system, and we've seen some encouraging work being done towards that. So the international movement is getting more power, and it's also helping us to provide services in the countries here. It's sharing our knowledge and experiences and also learning from one another. And I think that's a very encouraging sign to see. So pretty much in closing, I just wanted to show you some of the slides, what is happening with hospice and palliative care in the future, and where we are with the movement and thinking of going. So this idea of providing hospice and palliative care services early on in the trajectory, the area that is marked risk in the slide, is actually catching on, and we're also trying to venture out of the traditional cancer field. That was the start of the hospice movement, and still is the focus of the hospice movement in many countries, but we're also now providing services to people with terminal other diseases, also looking at neuromotorical diseases and other diseases that are people afflicting, especially in the countries here. So this is definitely the condition modifying care that then leads to death and bereavement care that is following this whole aspect. And in the final slide, you see that we're also talking more and more about community-based care, home-based care, services that are delivered to people anticipating deaths at a very early trajectory. And we're going into this idea of thinking about advanced directives, even more living wills, and now also providing legislation that is actually helping people to get the services they want, and also bridging out to people early on in the disease trajectory, which seems to be a huge help and hopefully the future of the movement. So I just wanted to finish up the thing by really acknowledging the partners who have done a lot of research in this area. The Diana, Princess of Wales Memorial Fund, who has given a lot of money to the international hospice and palliative care movement. Also the International Observatory of End-of-Life Care, and definitely also the National Hospice and Palliative Care Organization in the United States, which was a founding member of a lot of the international movement organizations, and is now also housing Fascia, the organization where John Mastrojohn works. So that is definitely there. And finally, I just wanted to leave you with the vision of that organization, which I think is really putting forward these things, a world where individuals and families facing serious illness, death and grief will expect the best that humankind can offer. And that's a really, really promising thing. So this was my short overview of the movement, and we'll now switch over to our keynote speaker, John Mastrojohn from the Foundation for Hospices in Sub-Saharan Africa, who'll talk to us about hospice and palliative care service provision in resource-poor settings.
Great, thank you, Chris. It'll take me just a moment to get set up here. And would it be easier if I sat? This seems more conversational, I think, if I'm sitting down. I feel like we're in my living room, so this is very nice. First of all, thank you, and thank you, Chris, for the nice introduction. I will tell you, when I was first asked to come to do this, I was delighted, and I've mentioned actually to a few people, Toronto is one of my favorite cities on the planet. So just to be able to come was really delightful. And I also want to thank Chris for really being such a wonderful host. I had both a night tour and a day tour at the university, and it is an amazing campus. I think I want to go back to school after being around here today. It was just incredible. So thank you, Chris, so much. The other thing that I know is that there are several sponsors for this lecture, and I want to thank those sponsors because I know there's a lot of ways that people can spend their money. Of course, I'm always delighted when people spend their money in ways that I think they should, like furthering hospice and palliative care development. But I wanted to be sure before I even started that I thank those sponsors really for their support today. So, Chris, thank you for really a wonderful introduction and outline for our topic today, which is addressing the universal human right for the challenges of hospice and palliative care in resource-poor settings. I'll give you just a quick overview. Certainly going to be talking about some of those issues. And an area, too, that I think is really just goes hand in hand with this conversation is really the undertreatment of pain as an essential human right. And I do want to share some of that information with you because, again, I think it just goes hand in hand with the topic. And then lastly, and probably most briefly, we'll talk about Fascia, which is the organization that I work for. We are an affiliate, as Chris said, of the National Hospice and Palliative Care Organization in the U.S. Fascia, just so you know, doesn't mean anything. It's not an African word, which we get asked all the time. We actually began as the Foundation for Hospices in Sub-Saharan Africa, which is a mouthful. So most of the folks that work with us just started calling it Fascia, which of course makes no sense if you look at how it's spelled. So we decided a few years ago we're just going to go by Fascia because that's what everybody's calling us. So we'll be talking a little bit about that as well. And then we will have an opportunity at the end for questions, both for me and for Chris. Which reminds me, I will also take up my watch to look at the time because I start talking and sometimes I can't stop. So, but we'll make sure that we're done at 1:30 as promised. So I wanted to start off with a question, really for the audience, and ask you, what do you think some of the differences are between providing hospice and palliative care in resource-rich countries and resource-poor countries? Just off the top of your head, what do you think some of those differences might be? Access to medicines, okay? And I'll repeat for the webcast. Access to providers.
That's what I was going to say.
Same, okay.
What about a cultural difference?
Yeah.
In terms of the religion, what they believe, and that whole thing of being fatalistic and having that kind of attitude that
Right.
life is. That's what it's meant to be for us?
Absolutely. So there are a lot of different cultural differences, differences related to spirituality or religion, which can also have an impact on the care. We'll actually be talking about that a bit in a moment. Yes, in the back.
Political involvement?
Political involvement? What do you mean?
I mean that perhaps in a resource-poor country, to sort of earn political will or to gain political support may be more challenging.
Absolutely. Okay. So really gaining that support, that political support, for really moving this agenda forward. Okay. Very good. There's a gentleman in the back.
Prioritization of limited healthcare resources into other areas that are probably more important.
Right. So looking at the prioritization of those, pretty scarce healthcare resources. And I think we certainly know there's been a lot of attention paid recently to even those countries that would be resource rich, and what are those resources and really where are they going? Absolutely. Yes.
So in terms of quality of life, a comfortable environment to be in, so access to a washroom, running water, sunlight in a room.
So really the basic needs. So what are those basic needs for care? And what are those differences in a resource-rich versus resource-poor countries, such as running water, access to food and nutrition, those types of things. Okay, very good. Yes?
I think there is an issue of awareness about the benefit of palliative care services.
Absolutely, that awareness. What is that awareness, and what are those benefits and advantages of hospice and palliative care? Yes?
Whether it's actually a healthcare concern or social concern, more the family involvement versus the institutional involvement.
Right. So what are those differences between family involvement versus patient involvement? That also makes a big difference. Okay. Last one.
I'm just wondering in terms of location, like where within the country is there one or two hospices in the entire country, whereas here, there are many different parts of the city. So
So access to the services, there are some places where there may be several different hospice programs in a resource-rich area versus resource-poor, and certainly that availability for those services will make a difference on who gets the care. Okay, all right, very good. Well, actually, I will say you hit most of them. It's certainly the ones that I came up with. So I just go down this list quickly. The higher amount of healthcare spending, and we certainly did have that as pointed out. The readily available training and education for healthcare providers. We certainly know, and I can speak to the U.S., Canada, that training is readily available for folks who want that training. Of course, those people, because that education is readily available, there are higher numbers of healthcare providers. That certainly does make a difference, and there's a slide I'll be showing you in a few moments relative to that. Funding streams for care. I can speak probably more knowledgeably about the healthcare funding, especially for hospice care in the U.S. We have a hospice Medicare benefit. It's this carve-out benefit of Medicare, and that is paid for the majority of individuals in the U.S. That funding stream is there. It's a continual funding stream, and hospices can rely on that funding to be able to provide the services. That is not the case in many resource-poor areas, that they have that stream of funding available to them. Systems of care. Systems of care are very different. Laws and regulations, standards of care, and certainly research. How do we know that we're really providing the best care? So I think we hit on most of those. The thing that I want to say actually before I move on is that what I'm going to be focused on, and I know we're talking about the differences between resource-rich and resource-poor areas. The area that I'm going to focus on is really sub-Saharan Africa. And when I started doing this work, I'm going to tell on myself here, when I first heard the term sub-Saharan Africa, I really wasn't sure exactly what that meant. So I thought I would help to define it for all of you, and I apologize if I offend anybody. But the term is really a geographic term used to describe the area south of the Sahara Desert. So you can see, what sort of my topics were that I was really good at in school and where I wasn't. And certainly geography wasn't one of them. So, challenges of providing care, and we're going to go through each of these individually. But looking at the high disease burden in sub-Saharan Africa, the issues of poverty, the healthcare workforce crisis, and that all leading to the inadequacy of palliative care in those areas. Another map. I love maps. Anyone seen this map before? Okay, I think the first time I saw this, it was actually printed in The Economist in 2010, and there was a gentleman who wrote the article who said that he is really trying to help people in a term that he actually coined, which is hemapacy, which he related to illiteracy, that most people don't understand these things. And when you look at the countries that are included within the landmass that is the continent of Africa, it's pretty amazing when you really understand the size of the continent, which really contains the whole of the United States, Eastern or Western Europe, China, Mexico, India, Iberia, and Japan. So when we talk about this, I think it's really important to see and understand sort of the size and the scope of the continent as we're talking about some of these issues. This is very, very telling to me when I first saw it, and something that I wanted to share with all of you. So disease burden, certainly I think everyone here is familiar with some of the issues that we talked about, especially as it relates to HIV and AIDS in sub-Saharan Africa. That there are, over 22 million people who are living with HIV and AIDS on the continent, which constitutes about 67% of the global disease burden. So obviously a disproportionate amount of people who are infected with HIV in sub-Saharan Africa. In 2009, there were 1.8 million new infections that were reported, which is interestingly equal to the total number of AIDS deaths globally during that same time period. So the epidemic is still certainly way out of proportion when compared to other regions of the world. And then also there were 600,000 cancer deaths And that's something too that I think is really getting a lot more attention these days, talking about non-communicable diseases in the developing world, resource poor areas. There was a high-level summit just a few weeks ago in New York City to address this issue of non-communicable diseases. Because what we know, both in the developing and developed world, that this continues to increase. And of the 57 million global deaths in 2008, 63% were due to non-communicable diseases, which are principally cardiovascular diseases, diabetes, cancers, and chronic respiratory diseases. And the majority of those occur in low and middle income countries, and really are the most frequent causes of death in most places across the planet, with the exception of Africa. However, there is great concern that is increasing on the continent. So when you think about what's happening with infectious diseases and the predictions for the increase in non-communicable diseases, it's really quite frightening when you think about sort of the impact of that. And there are projections that these non-communicable diseases are really rising quite rapidly, and that in fact by 2030, they really are projected to exceed communicable diseases in most African nations. So it is something that is getting a lot of attention now, and deservedly so. Poverty, certainly another issue that I think needs to be addressed when you're talking about these kinds of issues. The number of individuals living in poverty in sub-Saharan Africa, this is my word, is staggering. When you really look at, and this is the World Bank organization's definition of poverty, is really those individuals living on $1.25 or less per day. And of the total population of those living in sub-Saharan Africa, 51% are living at or below that level, which is pretty significant. And it's really the largest population when you compare it to other regions of the world. And this graph shows that. I mean, certainly there are other regions where there are higher numbers of people who are living in poverty, but percentage-wise, I mean, we're really looking at about half of the people who are living in that region who are living on less than $1.25 per day. The health workforce was mentioned as an issue. The World Health Report, the most recent World Health Report, identified 57 countries that are facing a critical health workforce crisis. And how they define that is really that each of these countries has fewer than 23 health workers per a 10,000 population. And a recommendation, or really a result of that report, said that sub-Saharan Africa really faces the greatest challenges because they have 11% of the world's population, 25% of the global disease burden, yet less than 3% of global health workforce is there, and less than 1% of health expenditures worldwide, which is really certainly something I would use the word crisis to describe that as well. This graph just shows the number of hospital beds per 10,000 people. The global average is 25 hospital beds. In the US, that number is 31. But you can see here in the Democratic Republic of the Congo, that number is 8 per 10,000 people, and Ethiopia just 2. So when we talk about sort of that infrastructure, what does that look like? I think this gives a really good picture to help understand that infrastructure for healthcare as it relates to number of beds. So let's shift gears a little bit. We're sort of talking globally about issues related to healthcare workforce issues and poverty and also disease burden. But I want to sort of bring it down just a little bit of a narrower focus now and start talking about some of the palliative care needs. It is actually, this was a quote from Harding and Higginson, who wrote in The Lancet that said the majority of Africans with life-limiting illness have at best limited and at worst non-existent access to palliative care. It really is not available for the majority of people who need palliative care. Chris pointed out actually on the world map of the countries that really have no identified hospice or palliative care activity, and it's 45% of African countries, and there's only 9% that could be classified as really having any kind of services that are approaching integration. And if you recall from his map, those countries that are approaching integration in Western Europe, in the US and Canada, those are the countries really that we're looking at, fully integrated palliative care. And it is, and I think in some cases, rather generous to say that it's 9% of those countries in Africa. And there are several key indicators for palliative care provision, just to sort of give you a better idea of what those are. That would be related to management of pain, development of national policies, and then integrating that curriculum for health professionals, relative to hospice and palliative care, really what that specialty is all about. There are only 4 African countries that have done that in their national health plans, and that's Uganda, South Africa, and Tanzania. Kenya, most recently, in fact, it was about 6 weeks ago, just integrated palliative care into their national cancer plan. So they're the most recent to do that, and it was really the result of some very hardworking people. Dr. Zipporah Ali, in particular, who is the executive director of the Kenyan Hospice and Palliative Care Association, and her staff, and a lot of other advocates in Kenya that were able to make that happen. So that was really something worth celebrating. I happened to be in Kenya just after that happened, so it was really good to be able to be with them and to celebrate that achievement. And then there are 2 countries that have developed sort of standalone national palliative care policies, and that is Rwanda, which is a most recent development, as well as Swaziland. So those countries are moving ahead rather quickly in developing some of those policies. So it's good to see that movement forward. This is a close-up, actually, of Africa, of the picture that Chris showed earlier regarding integration. Although I think this is using different colors, but it's from the same source, which is the International Observatory on End-of-Life Care, that is showing those countries that are approaching integration, which are listed at 4, and then, of course, those countries in between, and then the majority, which really have no hospice or palliative care activity that have been identified. So again, I think you're seeing a theme here. I do love maps, so I think it's helpful to see that. So Chris already talked about the definition of the World Health Organization definition of palliative care, so I won't go into that again, but I put it up here just as a reminder, but also then to sort of move into palliative care in Africa, and really how does that definition fit palliative care on the continent. And I think, and it was this lady here up front who pointed out about really looking at palliative care within within each country. I mean, it's very important to understand sort of the context of palliative care, especially as it relates to the culture. And we certainly know, as palliative care has been developed over the last several decades, that in order for it to be effective, you really do need to adapt to certainly the country and the culture and the context for palliative care to be effective. Also, I think it's important to point out, in resource-poor settings, social circumstances really may be a major source of the person suffering, and oftentimes will become the key focus of the care team. And I think that's something that, certainly in the U.S. and in Canada, that does have an impact on the care that we provide for our patients. But I think when we're seeing those patients in Africa, it does become more of a focus because it is a greater issue. So it's difficult, I think, and it certainly was a challenge for me, I'll be quite honest, is having worked in hospice and palliative care in the U.S., I had this sort of U.S. vision of what palliative care and hospice really looked like. And then I traveled to Africa, and it was very, very different for me to really understand how it was different, because it is more than, when you think about the scope of palliative care. We don't talk about as much in the U.S., certainly about nutritional support, for our patients. I mean, it does happen, but it doesn't happen that frequently. It is a major issue for many hospices when dealing with patients in various parts of the continent. and also care for orphans and vulnerable children. Now that many hospice programs now will provide, resources for people, certainly for their families. We have worked with hospice programs who have set up orphanages because certainly as a result of the AIDS epidemic, many of the patients they care for, their major concern as they're dying is what is going to happen to my children when I'm gone. And that is certainly understandable. So, we see that frequently with some of the programs that we work with, that, the care of those children becomes paramount. And other issues, bedding and clothing is also an issue. So you can see that, thinking about hospice care, for me, I really had to broaden my scope and think about it very, very differently because it is different, but again, based on the country, the culture, and the context. Another issue that was brought up at the outset was about medication. And I think it's important. And why is it that we talk about medication and think it's so, really vitally important in palliative care? Let me ask that question. Especially when we're talking about pain-relieving medications. And I know we have some palliative care professionals in the room, so I'll pick on them. Why is it such an important part of palliative care?
People can't focus on anything except pain when they're in pain.
That's right. People can't focus on anything else other than their pain when they're in pain. We talk about all of these other things that I just described, but it's really, really hard for people to focus on anything else when they're having pain.
Also, due to lack of pain medication, other systems in the body may start breaking down, needing more costly medication.
Right, right. And I also think too that, if anyone here has experienced serious pain, it tends to sort of exacerbate all those other things that we're dealing with too, doesn't it? Something that we could deal with quite easily, we may not deal with it in the same way when we're experiencing severe pain. So I think it's really critical that we have this whole conversation about issues of pain medication where we're talking about hospice and palliative care. What we know is that the vast majority of morphine, which is really considered the gold standard for the management of severe pain, most of that is consumed in industrialized countries. In Africa, the regional mean was 0.33 milligrams compared to a global mean of almost 6 milligrams. And utilizing the World Health Organization estimate of the need for palliative care, which is about 1% of the country's total population, there are approximately 9.6 million people who are in need of palliative care across Africa on any given day. The morphine consumption, again, just sort of a graphic representation of what I just mentioned. Global mean being about 6 milligrams, and you can see, certainly in some African countries, that it is less than half a milligram when compared to other countries. And this is actually from the International Narcotics Control Board, who studies this. Another thing that was mentioned when we talked about the differences was the training for healthcare workers. And it's really one of the main barriers or obstacles to the provision of good palliative care and pain treatment services for many people is the lack of training of healthcare workers. Many don't have an understanding of palliative care. It's not part of their training at all. It's not part of their experience. And there's also issues relative to the use of pain medication. And there still are a lot of myths about morphine and other opioids that many people still believe are true, specifically around causing death of the patient or issues relative to addiction. And those myths still exist. I had an opportunity on the same trip that I mentioned to Kenya. I was able to go to Uganda, and the Palliative Care Association of Uganda just had their biannual conference. And several of the staff I went to their sessions were talking about this whole issue of interviewing staff, both in the hospital and outside of the hospital, on their knowledge, attitudes, and beliefs around the use of opioids. And many of them still had these beliefs about either, you know, the patient would take the medication, they would die prematurely, or that they were afraid of the patient being addicted to that medication. So those myths still exist currently, and there is, I think, a lot of education that needs to be done to help people understand how to safely and effectively use this medication. According to Human Rights Watch, they just did a really wonderful report that is available online. It was just released in May of this year. That said, you know, key informants from 16 countries reported that people were reluctant to use these medication because of these exaggerated fears of either, you know, dependency or respiratory distress in the patients. Also, as part of this report, it says that the palliative care and pain treatment gap really is an international human rights crisis. The emphasis is my own, but I do believe that it's a crisis that needs to be addressed urgently, both at the international and national level. And what I've done is I've actually taken a video here that I'd like to show you now. It's about 2.5 minutes, and it helps to address some of these issues, I think, in ways much better than I can. But really talking about this whole notion of this conspiracy of silence around the use of the safe and effective use of opioids.
There are a lot of people suffering around the world, and we really have the knowledge and the experience and the medications available to stop it. There's not the political will and maybe the voice of the population driving it. And I think that's what makes everything so frustrating, is that we could do it.
Great scientific advances we have made. The international pain community certainly has reason to be proud of itself. But perhaps there will be a touch of shame because of the implementation gap.
There is an enormous crisis in untreated pain, and one of the reasons that I think makes it such a crisis is that pain is such a treatable problem.
This man, after 5 Indian rupees worth of morphine, could sit up and have a cup of tea. Collective voice is necessary, and they have no voice. They are mute. We need to be their voice. Till then, we are not getting anywhere.
There are many world problems that we don't have the solutions to, but we absolutely have the solution. And so what that means is millions of people are dying in agony, and that doesn't have to be.
Their suffering is mute. They have no voice. If they scream, it's heard in their neighborhood, nowhere else.
Much as governments have other priorities, ensuring that patients can access pain control medicines doesn't change a lot to their budgets.
80% of the globe out there remains in darkness. Until we have a strategy for that 80%, I believe the global community has failed.
It is our responsibility, each one of us. We are not going to put the blame on governments only, on the policymakers only. I think we are the policymakers in our capacity. Because whether I'm in a community, whether I'm in a hospital, I have a role to play. Even if it's just to tell someone that actually you can get a service in this area, we're playing a role. So we all have a responsibility to contribute towards improving the suffering of patients.
Well, I think it's quite well done. I appreciate you watching that with me. I've seen it, I don't know how many times. It's actually just a small snippet. There's a group that's putting together actually a full-length film called Life Before Death. And this is just one of the, they call them a trailer, really, for the film. I encourage you to go to their site. They have many of them. that are there. But I think that the point that it makes so well is that morphine is readily available. It's very inexpensive. I mean, we heard Dr. Raja Gopal, who said, for 10 cents, it made such a huge impact in this man's life who he was caring for. So we're not talking about medications, like protease inhibitors or other kinds of medication that are extremely expensive. We're talking about medication that is readily available, that's inexpensive, that's been around for many, many years, and people know how to use safely and effectively. And I think that is the frustration with working in some of these areas where that access isn't there. And what actually I was talking to Chris about this yesterday. Some of the frustration, we're working on a project now, is that where this medication is available and there are laws and regulations in place, what happens is they will frequently have stockouts of this medication. So patients will be treated with the medication. Their pain will be under control, and then there is no more medication, which I think sometimes is even worse. To know that you've had relief from very severe pain, you've had that treated, and then there's no medication that is available for a period of time. It could be from days to weeks to months. So we're working very hard with several organizations to make that medication not only available, but consistently available, so that people can use it and that their pain can be treated both safely and effectively. So I want to go back and just sort of review some of the barriers to palliative care and pain treatment. And we've talked about these, but I think just to sort of put it in some kind of a framework, is really the lack of health policies to support palliative care development. This sort of poor availability of these essential medications, the lack of relevant training for healthcare workers, and then the lack of strategic and business plans, standards, guidelines actually that Chris mentioned in the introduction. Those are really the key barriers to palliative care and pain treatment. So how do we address those? I think that's the key issue, is really looking at, we now know what all of these problems are. What are our next steps in addressing them? And this is a model that was first published in the Journal of Pain and Symptom Management in May of 2007, talking about a public health strategy and really the importance of a public health strategy to address some of these issues. And really looking at sort of the policy being sort of the umbrella to help to address some of these issues related to drug availability, education, and then certainly implementing all of that within the appropriate context. So I want to just sort of break those 4 areas down just a bit. And we mentioned some of these were mentioned earlier, about palliative care as part of the National Health Plan and policy. We know that there are the 3 countries that have it as part of their national policy, now Kenya that has it as part of the National Cancer Control Policy. Those are some really positive movements that are being made. And then, how do you fund some of the service delivery models to support that delivery of care and those essential medicines? Some of the countries now are funding, at least parts of hospice and palliative care on the continent. But others will say things like, we have a very limited budget, and I think it's to the point that you were making earlier. We have this very limited budget. How much of it really should be spent on palliative care when we can spend money on antibiotics? And it's really making some of those really, really tough decisions. Drug availability, we certainly talked about opioids, other essential medications. There has been a really strong focus on opioids, but as over the past really several months, many conversations about other essential medications that are extremely helpful in the management of pain. So it's not just morphine, but there are other medications that are really helpful for neuropathic pain, other types of pain that can be very helpful. Again, not readily available. Education. Education certainly for health professionals, and I think it was the point that you were making earlier too about making sure that families and caregivers really understand what is available to them, what are some of those advantages, and also just how do you put this out into the media? It's really powerful if you have those opportunities to put some of this out through the media so that people truly understand. And then of course where they say the rubber hits the road, is the implementation of all of it, and looking at those, what are those strategies, what are those business plans, and certainly where are those resources to sort of move that all along. So I think that this public health strategy really does help to address some of these issues, and in a way that is very, very comprehensive, and has certainly gotten a lot of attention over the past several years. There are many committed organizations, certainly, to move this forward. The World Health Organization, there are international associations, both related to pain and the control of pain, as well as advancing hospice and palliative care. Human Rights Watch has been doing a lot of work in this area recently. The European Association of Palliative Care, the African Palliative Care Organization, which is the continent-wide organization based in Uganda, and then of course national organizations, and Chris mentioned these earlier, US, Canada, UK, many others, and then to a much sort of lesser extent is Fascia, which is the organization that I represent, and I think I explained earlier, just to sort of segue into talking a little bit about the organization and the work that we do, that we were sort of formerly known as the Foundation for Hospices in Sub-Saharan Africa, and were founded in 1999. There were a group of hospice professionals from the US who traveled to South Africa to meet some of their counterparts in South Africa, and found out how absolutely overwhelmed they were with the AIDS epidemic, and said, we just really didn't even know what to do. So we said to them, tell us how we can help you. That was really the start of Fascia in 1999. And then in 2004, it became an affiliate of the US-based National Hospice and Palliative Care Organization. And the mission of the organization is to build partnerships so that we can really enhance that, compassionate care. We use the term compassionate care because there's a lot of misunderstanding about, sort of hospice and palliative care and how those terms are used globally. So we just use the term compassionate care. And we build those partnerships. Right now we have 93 partnerships between U.S. organizations and like organizations on the continent of Africa. Our primary partner in our work is the African Palliative Care Association, which again is located in Uganda. And we work very, very closely with them in order to move this work forward. We promote those partnerships between the programs. That's our primary work. We've also been very fortunate over the past several years to get grants and donor-supported projects. This NPI chat program was a new partner initiative through USAID, specifically through PEPFAR funding, which was the President's Emergency Plan for AIDS Relief in Africa. We were very fortunate to be the prime recipient of a grant, which was just over $4 million. We had that grant, we ran it for 5 years, and as a result, we're able to work with the Lutheran Church of Tanzania, and we're able to establish hospice programs at 13 sites throughout rural Tanzania. It was a very successful project. It just ended this year in April, and one of the things that we were able to do, because we have the partnership program, is all of those sites that were started are now partnered with the U.S. partner. So they get continued technical support as well as financial support from those partners. So we were able to sort of link what we do in that way very successfully, and are very proud of those accomplishments. We have also worked with the U.S. pharmaceutical industry, and I'll be talking a little bit more about that project in a minute. And then, of course, our collaboration with the International Palliative Care Community, all those organizations that I've listed, really to advocate for quality hospice and palliative care. This map shows where we have our partnerships. I think I mentioned just a moment ago that we did start the organization in South Africa, so it does actually have the most partnerships anywhere on the continent. But we are actually growing quite rapidly, and our goal is to actually increase the number of partnerships by 20, and I'll talk about that in a moment as well. Our impact in 2010, there was over $450,000 that was sent directly to our partners in Africa. And again, these are U.S. hospice programs that are partnered, and they raise the funds, they send the money to us, and then we really serve as the agent to wire those funds so that we make sure that they get to where they're intended. Very challenging process at times, but it's something that we do. And that does not include the $122,000 in in-kind donations, which were sent directly from partners or through other organizations with medicines and supplies, those kinds of things. And we are really proud of the fact that that really does support so many different people. Nearly 3,000 staff, over 3,800 volunteers who were really supported, and of course went to exactly how we do all this work. The 60,000 patients and 300 family members that were really served, and served, I think, in a better way as a result of those partnerships. The Pain Management Initiative, I mentioned briefly a few moments ago. We are working very closely with the African Palliative Care Association. In fact, we are partners in this project to focus on training hospital physicians in pain assessment and management, specifically around the use of oral morphine. We've actually done a rollout of phase 1 of this project, which involved representatives from the Gambia, Kenya, and Malawi. That was in February of this year. And then we just rolled out phase 2 of that project last month in Swaziland, Zambia, and Rwanda. It was really, all of that funding was provided by a consortium of pharmaceutical companies and other donors in the U.S. that was led by Endo Pharmaceuticals, who've just been an amazing partner for us in this whole program, because it was very difficult for us to be able to make the case to U.S. pharmaceutical companies. We were able to get the support from Endo, who was really able to open many doors for us to help to explain some of these issues. And in fact, Faith Mwangi-Powell, who is the Executive Director for the African Palliative Care Association, was able to come to the U.S. And we had her speak at the PhRMA, which is the Pharmaceutical Research and Manufacturers Association annual meeting last year, which really brought a lot of attention to some of these issues, and we were able to get support. Because and I know Chris has heard her speak, if you've ever heard Dr. Faith Mwangi-Powell speak, she is very, very compelling. And she was in rare form, as she always is, and Bruce really did a wonderful job in helping people to understand these issues. We're also working on a program. We had a donor established a scholarship fund, again, which is another project that we're working on in collaboration with the African Palliative Care Association to support African nurses in furthering their education relative to palliative care. So it's not a scholarship fund that helps students to get through a nursing program, but these are nurses who already have been through a hospice program and then to get additional education for hospice and palliative care, either through a diploma or a degree program. And that program was actually started last year, and we were able to award 11 scholarships this year. And that started because the social workers did not want to be outdone. So they said, we want to start a fund for social workers. So the National Association of Social Workers has spearheaded that program, and they are raising those funds, and they have promised us $20,000 by the end of this year. In fact, they are almost there. I heard from them recently. And we will have a similar fund for social workers in Africa for furthering their education in hospice and palliative care as well. The need continues. Right now, we have, sitting in our office, we have applications from 20 African hospice programs who are waiting partnership. And some of them have been waiting for quite some time. We advertise about our partnership program very frequently. But I think there's been certainly in the last year and a half a lot of attention in the U.S. on funding for hospice programs. We think that really as a result of that, it has slowed down our progress for new partnerships. So we're actually given the time difference, I think that probably right about now, this program that One Cause, Two Continents is being launched almost as I speak in San Diego, which is where the National Hospice and Palliative Care Organization is having their clinical team conference. So this campaign is being launched this morning at the opening of that conference. And what our goal is to be able to partner all 20 of those pending African partnerships by March 30th of 2012. And we've chosen that date because it's the date of our next conference, which is the Management Leadership Conference in Washington, D.C. So we really want to be able to, once we get to that conference, be able to celebrate the fact that we've been able to partner all 20. Certainly keep your fingers crossed. We're hoping to be able to reach that goal by March 30th. We do want to allow a few minutes for questions, but before I end, I do want to thank again Chris Klinger, for the invitation, for all of you, certainly for again for the sponsors for this event, to thank the Fascia team, the African Palliative Care leadership and staff who I learn from every day, and certainly again the reason why we do this all for the patients and families that we all serve. So I'll ask Chris to come up and join me, and we'd just like to take a few minutes and see if you have any questions for us. And I feel like I talked really, really fast, so hopefully not. I feel like an auctioneer. Yes.
Thank you for the very informative presentation. It's great.
Thank you.
The question I like to ask is, we're talking about all these organizations. How do you grow this from the grassroots up? And in terms of your medication, are people suspicious of what foreigners are going to bring in? They must be taking some of their own, their own potions before, which they feel comfortable with because they know them, but they don't know what they're bringing in. So, and the curriculum, who helps to develop the curriculum? Does it come from the States and Canada or the European countries, or is it developed there?
Okay, so let's take the last question first. So the question was about really developing the curriculum, and where does that get developed? And I think that, as we often say, sort of nothing is everything is borrowed, sort of nothing gets invented. So I think a lot of the curriculum is adapted. I'm most familiar with the diploma program that's being taught through Hospice Africa in Uganda, which is based in Kampala. And they have really taken a curriculum from, I think borrowed from a lot of different folks, but have made it very, very specific to the African situation. And I think they just do a phenomenal job in their training. The other question was about sort of the grassroots sort of movement of all of this. That is one of the things that I think is really interesting, and I can speak from the U.S. perspective, which is sort of the whole start of Fascia in particular was really a grassroots movement, I think, of just like-minded colleagues who went to visit and said, these people are really in need of some help. That sort of was the basis for the founding of Fascia. And I think that work continues because what I see, from my seat is really sort of the macro version of it. But then when I go and visit the U.S. partners and I see it's really a community program, because many of the hospices say, they have an opportunity to introduce this work into their own communities. And that's where they get a lot of buy-in and support. And I think that grassroots movement in the U.S. just continues to grow to support these kinds of programs, which to me is really sort of a fascinating outcome of this kind of a program. And I will have to admit that I don't remember what your third part of your question was.
That was too many.
Because I'm old. No. I remember these things.
And someone was talking about it. No, it was the whole thing about the morphine and how they're suspicious of, and I'm just wondering, like they're used to taking their own, over generations. And are they suspicious of what people are bringing in? Because there's so many programs that happen and so many changes that in a place where they're used to doing things their way, all of a sudden, who do you trust? Like, because there's too many changes.
Yeah, and I think too, it goes back to that whole notion of, this being in a sort of an appropriate cultural context. And I had the opportunity, I mentioned earlier, when I was in Kampala to attend the Ugandan Palliative Care Conference. And there was one of the U.S. partners actually is partnered with the, not a hospice program, but the National Association, the Palliative Care Association of Uganda. And they were able to actually produce a film. And one of the issues that's addressed in the film, which I think is brilliantly done, is how do they work with traditional healers? Because I think there are many people who've relied on, for centuries, these traditional healers, and it's just part of what they do. And one of the issues that was brought up, because there was the screening of this film at this conference, was how do they work more closely with those traditional healers? And there was a gentleman in the audience who was considered a traditional healer who said, I would like to work with you all collaboratively to understand this, because he really felt that that would help him in his practice and certainly help the patients he was caring for. So I think there was I think a bit of surprise that certainly from the people who were attending, that the traditional healers would be open to those kinds of things. But I think that would be a way that would be very helpful to address the issue that you brought up, that traditional healers would be working collaboratively with people who were introducing, medicine that was unfamiliar to them.
That's quite a hurdle.
It is a big hurdle with some people. Yeah. There's a question in the back.
I'll just preface the question by saying that I have an ongoing relationship with palliative care providers in Zomba and Malawi.
Oh, great.
And one of the things that we have, I guess, one thing that sort of raises that they actually have recently in the last few months finally has ministry approved their national palliative care guidelines. So there would be another way to add to your slide.
Thank you.
One of the things that we have struggled with in terms of the areas, most of the support that we've been trying to provide is within the public sector. Mm-hmm. And one of the things that we struggle with all donors, I think, in partnership organizations, is the desire to have a discrete hospice organization, faith-based organization, faith-based hospital, as the recipient, as the partner. Mm-hmm. And if the partner is government and public sector, everybody kind of has a bit of a struggle to know what to do with that, particularly when it comes to things like approving funds, monitoring funds, transferring funds, the practicalities of actually moving some of these things forward in implementation. So I just throw that, maybe a longer conversation to have afterwards, but I throw that out there as just from experience, something that we have certainly struggled with in terms of trying to move things forward within the public sector. And I think to speak to your point about the grassroots, while the grassroots are the community, the grassroots or the system is really, in many cases, it's important to really pay attention to the public sector because, at the end of the day, most people in many countries in sub-Saharan Africa, their healthcare, if they're getting any, is being delivered to them by the public sector.
Right. So, I appreciate your point. Thank you. Thank you very much. Question?
I'm not quite sure how to ask the question, but my experience has been in rural communities and most populations in rural areas. And they don't talk about palliative care or compassionate care, but home-based care.
Right.
And so I was wondering if you could speak a little bit to the connection or lack thereof between the two.
Yeah, I can. The question was about home-based care, especially in the rural areas, and I can actually speak to at least one project that I'm familiar with, which is the project that we did in Tanzania, and it was very specifically for establishing hospice palliative care services, home-based care services in rural Tanzania, and I think one of the things that worked out so beautifully in that program is that the volunteers, and that's what they were called, though they were paid a stipend, were people who lived within the rural community. And they were the reason that project worked. Because I think, you can take people from the health system and send them out to the community, but when you send them out to the community, the people in the community don't know who they are, And the people that were the volunteers that were a part of that community were able to introduce this in a way that it came from a trusted source. And quite honestly, I don't think the program would have had the success that it did if it weren't for those individuals. And it was very interesting because most of the people were well known within the community when it started. Some were not, and the ones that weren't really, they were able to establish some relationships that afford them a lot of respect within the community. And I
I've
think
seen
that
the successes as well.
yes,
But it has a lot of problems attached to it in terms of sustainability. They can't get the drugs,
correct.
et cetera, et cetera, et cetera.
Right.
So I'm just wondering if you've had experience where there are projects where it has been sustained, because volunteers are the women.
Correct.
They have their own issues, their own families, their livelihoods, they have to work on the farms, et cetera, et cetera, et cetera.
Yeah.
And the programs that I'm aware of and I've worked with have not been sustainable when the funding dries up. The
Right.
stipends disappear.
And that isn't
So-
the main issue. And one of the things even with stipends that we learned from people is they were saying, you know, I get this stipend, but then I go to, you know, see an individual in the community and, you know, they need food. You know, and they give it to them. You know, so it's like this little stipend that they get it really doesn't go that far, and that has become an issue. And I think it was one of the reasons where we were so determined that we would have a U.S. partner for each of those sites, because our concern was, I mean, we certainly can't fund them in the way that the grant did, but we're still able to provide that stream of funding. So, you know, that's been sort of our small contribution to some of that sustainability, is they're still able to get those funds, and they sort of channel them through those resources, which I think are helpful. Yeah, but it's a big issue for sure. Gentleman in the back.
In one of your slides, you showed that Africa has 25% disease burden at less than 3% of the healthcare workforce. And that joined the question that has been asked about how can you reach the needy with less than 3% of healthcare workers force. That's why I think some of the programs started with community volunteers. Of course, the issue of sustainability is real because we need a stream of funding that can sustain the activities of the volunteers. But there have been several forms, several approaches in working with the volunteers. And one of them that worked is to ask the community to delegate or select the volunteers. That's the model we have used in Malawi, in the site where I'm working. And this has worked very well because the volunteers are not paid. The volunteers are sustained with some gathering to exchange their experiences, their success and challenges. And it has been actually the basement of the palliative care services and the hospice model we have developed. There is still a problem in terms of training though, because there are very few physicians, and if you want to train nurses to upgrade, I think the Uganda site has limited number of places. Yes. So even if you have people who would like to upgrade their training, they can't get in. The intake is still limited. So there is an effort to be done at that side. I like the model where you have the policy and then on one side the education, the drugs. But really on the training side there is still huge challenges, and it will take years before we get where we would like to go.
I would agree with you completely, and I think that's one of the things that we saw, especially with this nursing scholarship program. We had so many applicants, you know, for that program, and you know, we thought even if we had the funding, which we didn't, you know, to be able to give to everyone, there wasn't a place for them, you know. And except that the program in Kampala is really a good program. They just don't have the ability to take as many people as they would need. And of course, there's just an increased cost because if somebody's traveling from Malawi, you know, they need to be able to, you know, have their costs covered for travel as well as lodging. You know, so now you're talking about a program that is 2, 3, 4 times as expensive to be able to do that. So, you know, hopefully, you know, those types of programs, you know, will start in various regions across the continent so that they are more accessible for individuals to be able to take that type of training. It's a challenge for sure. Yeah. So thank you. Appreciate it. Yes.
I was just going to ask, keeping in mind the barriers identified as being lack of training for healthcare providers and this question touching on that. Are there any, like, do you know of any work or volunteer programs that kind of bridge the skills and experiences of healthcare providers in Canada and U.S. to go and offer those skills in resource-poor settings?
Yeah, there are several different programs that do that. It's certainly a question that we get asked all the time. And actually, what we're doing right now is we're putting together, and we're going to have it on our website, hopefully in the not too distant future, is to be able to give some guidance to people to help them understand, where they can go, because we probably get to ask that question at least every other week.
Yeah.
Because people really do want to be able to do something. So we're putting together that resource right now. So.
Because I found everything that I've looked into, like, you've had to pay a lot of money to volunteer.
Correct.
And so I was just wondering if there are any pockets of money to support. You know what I mean?
Yeah. So we're trying to gather all of those resources now and make it available on the website.
Great. Thank you.
Okay. I think we've got time for just one more question, and then we'll certainly be here afterward too. So.
Given the crisis in very basic needs and pain management, is the organization that you work with and your associates, is there any movement in bridging spiritual care needs? Or is that sort of down the road? Is that just...
It's not part of what we're doing right now. But I do know that there are a lot of organizations, certainly some of the organizations based in Africa are really working to move that forward. In fact, I heard a wonderful presentation when I was at the Ugandan conference from a spiritual care leader who is one person in particular who is really doing a lot of work to get more attention paid to the issues around spirituality for care of patients in Africa. So I'm not aware of any one organization, but I know there are certainly pockets of individuals and organizations who are working toward that end. And it's a critical component of palliative care. So it certainly is nice to see that someone is paying attention to it.
Thank you.
Okay. Great. Well, thank you for your time and attention today. I really appreciate it. Thank you.
Thank you very much for today. We have a small token of appreciation for each of you for.
Thank you
so much. Thank you.
Thank you.
Thank you.
Just to let you all know, there's